Good evening, friends. And today is the Thursday evening, and the whole CCI team is back with another new topic for all of us, that is community pulmonology. And today's webinar would be on capturing data in pulmonology. So on behalf of the whole organizing team of CCI, I am Dr. Radha Munje, and I welcome you to this wonderful webinar which has not ever been held on CCI forum or even at other forums also. And today's topic, as you know, is community pulmonology. There will be two presentations. One would be done by Dr. Animesh Jain and the other would be done by Dr. Chakrapani. And after this, there is going to be a panel discussion. The main purpose of this webinar is to encourage people to take up research, collect their own data in whichever field they are working, whether they are private practitioners or in government sector, working individually or in a corporate sector. They should collect their own data and they should be able to bring out something from that data, which is then the ultimate goal is making a publication out of this so that the whole fraternity is benefited by your own experience. I know that it's an ultimate goal of all practitioners to have some publications in their name. And I think this would be a wonderful start to go ahead in that direction for all of us. So our first speaker is none other than Dr. Animesh Jain, who is a professor and head of community medicine at KMC Medical College, Mangalore. He's head Mangalore Unit of International Chair in Bioethics. He's a Feimer Fellow. And he is also not only a teacher, but he's an epidemiologist, educator, trainer, motivator, researcher, and editor for few medical journals. He's an avid photographer, and he's a member of several national and international professional organizations. And then it's no wonder that he has won the best innovative practice in teaching and training of community medicine in 2019's IAPSM National Conference. And then I welcome Dr. Animesh to deliver his talk on collecting data or capturing data. Our second speaker is Dr. Chakrapani, who is a professor of medicine and a former associate dean and head of the Department of Medicine at Kasturba Medical College, Mangalore. He's also a director of clinical research at KMC Mangalore. He has several publications in the peer-reviewed index journal. And today's topic is a little innovative, and he would be speaking on pragmatic trials. And let us see what this is and how we can go about in that. So the stage is all yours, Dr. Animesh and Dr. Chakrapani. The first one would be Dr. Animesh delivering his presentation.
Thank you, Radha ma'am, for that kind introduction. And I would like to thank the CCI office bearers and both the trustees, that is Dr. Krishna and Dr. Pradeep, Narayan Pradeepa, for giving me this opportunity. I think this is my third webinar, so I'm very happy. We'll talk about something which is a very kind of untouched topic most of the time. So we will talk about how do we do research and how do we capture data in pulmonology. So with that, let's get into this. The objectives of the session are basically to outline the important steps for the clinical research in pulmonology, to describe the study designs for research with appropriate use of the collection methods and other methods of research, to list the various data collection methods with pros and cons. So what is a study? Very simply put, a study is a scientific process of answering a question using data from population. So that's the study in terms of scientific parlance. So we may want to know whether it is smoking linked to a particular disease like cancer, or maybe the differences between two places or two geographies. It could be the like we want to know about a particular foodstuff or an allergen, whether that is incriminated in some kind of a disease causation or some kind of allergy which manifests. So all that is basically a question that we are trying to answer. And this we do by using the data from population. So the whole research process, though it looks complicated, it's actually quite simple. And what are we trying to do? So basically we have a question, and then we design a study type based on what is my question that I want to answer, what I'm setting out to answer. And in fact, after that, I start looking at some of the literature, and then I try to collect and analyze the data. Once I have collected the data, many times we will have a load of data, or maybe sometimes we have a load of patients, and then we can easily collect the data. Once that is done, we need to analyze it, interpret the results, and then report the findings. We can, again, this report can be even as presentations and followed by even publication. So there are many different approaches to answer a particular question. A specific research question can be answered in different ways. Each of the study design based on what we take has its own pros and cons, and we must consider them, because if we are trying to go for the most optimal design, sometimes there may be feasibility issues, there may not be possibilities. So we need to look at them. So what we are doing is, in this session, we are confining ourselves to the most common aspects of research, and also looking at some of these commonest study designs, or the common ones, which now after my session, Dr. Chakrapani will follow with that, talking about pragmatic trials. So once we have the kind of question, then we select a topic, we do a literature review or search, and then we try to develop our argument or what we have said that this should be or this should not be. So once we have done that, then again we look into the literature, critique it, and then write a review of literature, and this process goes on. So we have multiple databases. I'm just touching on some of these because we'll go into panel discussion and then continue. Now, if you look at this, these are the commonest ones: PubMed, Embase, Scopus, Cochrane, all these we use. Now, just want to touch on one of the things because this has implications. Sometimes we get confused whether it's an incidence or a prevalence. Incidence is a new case, whereas prevalence is actually a sum total of old and new cases. So if you want to remember, one of the aids could be prevalence has AL, so all the cases, and that is divided by the population at risk. Whereas incidence is new cases. So N for incidence and N for new cases, and divided by the population which is susceptible or at risk. There are different types of research, qualitative and quantitative. As the name suggests, quantitative means quantity, numbers, whereas quality means we are trying to figure out what is their lived in experiences, what is the, there are certain things that we want to know about, or reasonings, and maybe go into the depth of it. So there are different kinds of research. We'll not go into specifics of it, but usually we go for quantitative research. Qualitative can be looked at for certain parameters, like maybe if we want to know why doesn't the patient come on time. Now, what are the reasons? So we can go for an in-depth interview, and we interview a series of people. And then if we find common themes, we can come out with, and we can say, okay, these are the most common things, then probably these are the reasons why they are not coming on time. So quantitative study designs, these are the ones we can have either experimental or observational. If we are just observing and then analyzing certain things, that's observation. Whereas if we are actively intervening, we are doing something, we are adding an intervention, we are probably having a comparison between a new drug and something else which was already there. So that is experimental. And those are the common ones, like randomized control trial and non-randomized control trial. One of the most important, or say gold standard in clinical research. But then we have the observational, even a case series or a cross-sectional, even case control and a cohort. Ecological is basically when we take the whole, say, if it's a particular cluster as a unit or as a geography as a unit. So then that's ecological. We don't go by individual as a unit. So just quickly to go through these. Case series is basically when we have a number of cases and then we are looking at these, and then there may be certain things which we discover. So if you look at unusual pneumonia in men led to the discovery of HIV. When we found that there was a seal-like limb present in the babies, so pocomilia, so that led to discovery that it was associated with thalidomide intake among pregnant women. So basically, it's a report of a series of cases, and then we look at a particular or maybe multiple sources, and we look at those things, we describe the characteristics, we try to find things. The advantage is it's fast, it's inexpensive, and leads to a hypothesis creation, which we can test out to figure out whether it's actually true or not in the subsequent studies. Disadvantage, we don't have a comparison tool. We do not have any kind of a method of sampling or statistical method of sampling which is used in this. And it is prone to bias. But this is useful because it helps us to generate hypotheses. It's informative for a rare disease, like I told you, when it was HIV or say pocomilia. And it may also suggest the emergence of a new disease. Even like, for example, COVID, when we started in a few cases, so we could get to know more about it. It starts with a case report and a case series. And it is useful in bringing attention to a new area. Coming to the next design, that is cross-sectional, which is one point in time, we collect all the data from all the people, and that's why it's cross-sectional. So if we have a population which is representative, then we can reproduce, or say rather take it back to apply the result to the entire population. So that is something which we have to keep in mind, that representativeness of the population. It could be retroactive or proactive going forward. It gives us the magnitude of the disease, and it's very useful in planning of our health services, interventions, etc. So this is kind of pictorial representation. It's something like a snapshot using a camera. So the advantage being it's easy, fast, it gives us prevalence rate and probably even a hypothesis, but it gives only prevalence. We do not get to know incidence because we are not going into waiting and seeing who develops disease new. And there is no temporal association, meaning what came first, chicken or the egg. So we do not get that temporal association. And it's of course not suitable for highly fatal disease or disease of short durations. Next is the case control. So as the name suggests, we have cases, we have controls. So cases and controls we compare, and that is related to any event, any disease or whatever. And usually this is done retrospectively. So we go back in time to find out any kind of history or investigations and associate it with the event that we are looking at. So it's a good design when we have rare disease or rare disorders, or diseases which have a very long latent period, because cases would have already occurred. So we have something to compare with. And then when there is difficulty in obtaining data or it's expensive, so this is a good design. So as I suggested, we can have cases and controls. Cases are the ones who have disease, and controls usually will not have the disease or the event or the whatever in question. And we will compare it with the past exposures. And this is how it goes. So we look at, in both the groups, we are trying to look at both the groups, the risk factor, whether it's present or absent, and then we analyze. So we start in present day, cases have happened, controls are already there, we select them and then compare. And we look at the data for the past. The advantage being rare disease, a smaller sample size relatively, there's hardly any attrition. It's the earliest practical observational study design that we can have, but it is prone to biases. As we are asking for a remembering from memory, there could be recall biases. There could be sometimes, interviewer biases. There could be different kinds of biases. If we take it from one particular source, Bergsonian bias. So those kind of biases may creep in. And there could be exposure changes after the disease has manifested, or disease can influence the behavior of people. That brings me to the next study design, that is cohort. Cohort is nothing but a group of people, a similar characteristic or maybe having similar kind of experience, and who are followed up for a period of time. Example as people working in a particular workplace, so occupational cohort, people who attended a particular say party or a function, or like you all attending a particular this workshop and then we follow you up to see what is the outcome, or birth cohort. So here what we are doing is we take a group and we follow them up. Please remember, as of now they are not diseased. In future they will get disease, but what is the differentiating factor is, here, these people are seemingly normal, but they have a risk factor present. For example, you take a population, there will be some people who are smokers, there are some people who are not smokers. Now, over a period of time, some of them may develop cancer, lung cancer. That's what we need to do here. So that's the kind of design. So there will be people who are exposed and not exposed, and we follow them up for the disease development. And then we compare between the two. So here we get something known as a risk. And the next one is what I think most of you are familiar with, a randomized control trial. It's an experimental study. So here the investigator controls what the variable, predictor variable will be. And that's in the form of some kind of a treatment or an intervention. It could be anything. The advantage is we have the ability to demonstrate that this leads to this. So here that chicken or egg thing, it does not confuse us. We have an ability to demonstrate an effect of X as if X leads to Y. And randomization usually is the heart and soul of this. It controls the unmeasured confounding which may arise. It's usually taken up for only mature research questions once we have some idea. This is the design of this particular trial. So basically we have one arm which is the treatment, the other one is control. We have randomized, and then we analyze them. It could be, usually we don't do placebo now, but sometimes for certain things, in some exceptions, it is available. So this basically shows you a overall kind of a summary of what kind of design you would resort to depending on what is my research question. So it depends on my research question. However, we have to collect data as well. So when I'm collecting data, now what I need to do is, I need to remember that the data can be collected either primarily or secondarily. That means if I'm doing it purposely for my research specifically, that has to be done by having some interviews, surveys, observations, whatever. But there may be already data collected and I can utilize that. So that kind of a thing is a secondary data. It could be patient record, it could be notes of nurse, anything. The advantage of primary data is it can be tailor-made to my needs and it's consistent, defined, its completeness can be ensured. But it is time consuming. It sometimes has biases and we need to check the reliability if I'm using somebody to collect that data from me. The secondary data is obviously easier, it's economical, time saving, and probably no bias because it's already there. But the completeness, accuracy, all that may be in question and may not be suitable for answering such questions which require certain depth analysis or which is not available in my records. And missed data and inaccuracy are very common problems here. So with that, this is the structure again to remind you. So we start with a problem, a research question is zeroed upon, and then we have the literature review, formulation of the objectives. We design the research based on what is the study design methodology, take an ethical approval, conduct a research, analyze data, and summarize, publish. So in our next webinar series on 2nd of November, which follows the second part of this, we will talk about the publication process and more of data presentations and others. So do stay tuned in. But right now, I'm just stopping here just to tell you that there are different types of articles which we'll take up in the next webinar. And with that, I'll stop here and I would request Dr. Chakrapani to take over and he will talk to us on pragmatic trials. So over to Dr. Chakrapani. Thank you.
Good evening. Practice and research should ideally be interconnected. A good practice should lead to good research, and good research will in turn lead to a good practice. But in India, practice and research are significantly disconnected. The practitioners feel it is difficult to do a quality research, and hardcore researchers find it difficult to devote time for regular practice. There is a need to bridge this divide. That's where pragmatic trials come in. Cambridge Dictionary defines pragmatism as dealing with things sensibly and realistically in a way that is based on practical rather than theoretical considerations. It's basically practical as opposed to idealistic. Doing traditional randomized controlled trial would be the ideal way of doing research, but then doing pragmatic research is actually being practical. The evidence pyramid for practice is as follows. It starts with an observational study. Please note that observational study is just hypothesis generating. It can't be translated into practice unless it goes through various phases of clinical trial. Even with the best of results, because of the possible confounding, observational studies only are considered as hypothesis generating studies. It should be followed by a phase 1, phase 2, phase 3 studies. Phase 1 basically for bioavailability study, phase 2 for toxicity study, and phase 3 is the main clinical study for efficacy. And only after phase 3 the new drug is marketed. So phase 3 is a regulatory requirement, and that's why it has to be a traditional randomized controlled trial. But then after that, when it comes to the question of using it in clinical practice, we have to look into the effectiveness. There has to be a subtle difference between efficacy and effectiveness. Effectiveness is how effective it is in the real life scenario. That's where post-marketing studies and pragmatic studies are coming into play. The randomized controlled trials can be divided into two kinds of studies. Explanatory trials, which attempt to test the causal hypothesis under ideal conditions. These are the traditional randomized controlled trials, or otherwise called as explanatory trials. Pragmatic trials are the ones which attempt to help clinicians choose between two treatment options in the real life scenario or the usual conditions. So in one, we have ideal condition where specialized centers are there, clinical trial sites are there, well-trained researchers are there, well-trained nurses are there, well-trained research unit is there, and there are very strict inclusion and exclusion criteria, very strict follow-ups. So it's a huge setup that is required for doing such studies. That has been the case with explanatory trials of randomized controlled trials. As opposed to that, pragmatic trials, they are done in the routine clinical settings, in the routine treatment scenarios, and without much of specialized settings, specialized trainings, or specialized selection of patients. But in reality, there is hardly any, in reality, there is a continuum rather than a dichotomy between explanatory trials or pragmatic trials. Most of the trials will fall in between these two extremes. They may have some elements of pragmatism and many elements of explanatory trials, but the regulatory trials have to be completely explanatory in nature. Explanatory trials answer this question, can it work? Whereas pragmatic trials answer the question, does it work in the real setting, that is in the real world scenario? The main question is whether it's valid, whether the results from the trials are valid or not. Both explanatory trials and pragmatic trials incorporate random allocation. That's why they do have significant validity. Whether it is pragmatic trial where there are a lot of flexibility, a lot of variations from the protocol, but still because it is randomized, it does have significant validity, that is internal validity. Explanatory trials, the conventional ones, have very high internal validity, but the pragmatic trials have got very high external validity also, although the internal validity is a bit compromised because of the flexible nature of the protocol. So then what is the pragmatic trial? What is the definition of a pragmatic trial? Pragmatic trial are the ones where clinically relevant alternative interventions are compared. It is not a new drug, it is or a new practice, something which is already existing in practice, but the two alternative medications or treatment strategies are compared. And you include diverse populations. You don't restrict yourself to a very strict inclusion exclusion criteria, because that's not the case in real practice. In real world practice, the patient population is not at all selected one. So the pragmatic trial will include such patients without much of a strict inclusion exclusion, with basic diagnosis, or the subjects are recruited, and it has to include diverse populations. and should be in different practice settings. It can't be only in a medical college center. It cannot be in tertiary care center alone. So it should be from various practice settings, from clinics, from general settings, from hospitals. So all the settings have to be there in an ideal pragmatic trial, and the outcomes have to be broad range of health outcomes. These are not laboratory outcomes. Pragmatic trials don't look into the reduction of HbA1c or reduction of blood pressure, but they generally look into the life saved, mortality prevented, or quality of life. So relevant health measures are the outcomes, not just laboratory measures. These are the definitions of a pragmatic trial. So this table shows the differences between pragmatic and explanatory trials. In a pragmatic trial, the objective is to compare the effectiveness of the healthcare delivery, whereas in explanatory trial, you want to look into the efficacy of the intervention. The setting in a pragmatic trial is routine clinical care, whereas in explanatory trial, it is an experimental, highly selected center. The patient population in pragmatic trials is heterogeneous to mimic the real world. There is little or hardly no selection involved in recruitment, whereas in explanatory trial, it is a homogeneous population to minimize bias. So it's highly selected. In a pragmatic trial, the investigators or the stakeholders are healthcare providers. The regular practitioner becomes the researcher here. Whereas in explanatory trials, you have got specialized scientists and sponsors who are mainly involved in explanatory trials. The interventions in pragmatic trials are often complex, bundled care or packaged care, and applied flexibility with treatment regimens. There will be flexibility allowed to the investigator. These are not rigid protocols, because that's what is seen in real life practice also. In real life practice, the patient may not take all the medications. He may have some side effects. The medications are changed. He may take some other medications along with that. So all this is part of a pragmatic trial. These are things which are not allowed in explanatory trials because everything is strictly controlled. The outcomes in pragmatic trials are health care outputs, whereas in explanatory trials of indirect biochemical evidences or blood pressure readings, some numbers will be there as outcomes. But in pragmatic trials, it should always be a clinical outcome. The pragmatic trials have got high external validity, rather lower internal validity, whereas explanatory trials have got less external validity but very high internal validity. Randomization in both of the trials. The sample size is generally larger in a pragmatic trial but smaller in explanatory trials. And often pragmatic trials are unblinded. Blinding is possible in pragmatic trials, but most often blinding is not necessary in pragmatic trials, although it may be desirable. But in explanatory trials, it's always blinded. There is no question of placebo control because in pragmatic trials, we are comparing two accepted modalities of treatment, whereas in explanatory trials, it can be placebo controlled also. And the long follow-up is always long-term because clinical endpoints have to be there. And explanatory trials, it's a short-term because we just want to look into the efficacy but not effectiveness in the long-term clinical practice. Pragmatic clinical trials they do require randomization as are explanatory trials. So randomization is always required, but blinding may not be there. Often it is compensated by having observer blinded protocols. The treatment plan is very flexible. The researcher is free to deviate from study protocol if it is in best interest of the patient, and treatment regimen may be tailored to the patient's needs. Sometimes consent may be waived in pragmatic trials, especially if the trial neither interferes with the normal clinical care nor adds non-standard activities or data collection. There may be a scope for consent waiver. Or if there is a cluster design wherein the clusters are randomized, the consent may not be required from the individual participants. So these are special characteristics of a pragmatic trial. And pragmatic trials are always done in a normal practice setting by the staff with the typical experience and with the use of routinely available equipment. You don't require specialized training, specialized settings for this. Routine healthcare or clinical practice setting, and participants may be receiving other healthcare modalities of treatment also. For example, if the patient is in an antihypertensive pragmatic trial, he may be taking alternative medications also because that's what patients do in their routine care. So that's not a contraindication for a pragmatic trial. The methods may have to be modified a little. A trial with blinded intervention is not fully pragmatic. So blinding is often not done in pragmatic trials, but then the moment blinding is removed, there can be an element of bias. So there has to be a balance between bias and pragmatism. So in some pragmatic trials, blinding may be required to maintain good validity and avoid bias. Typically, there are very few, if at all, any selection criteria other than the presence of disease or the diagnosis of interest. Unlike exploratory trials, many severity of the disease or the age or other comorbid conditions are not contraindicated in pragmatic trials, because in the real life practice, you don't want to exclude patients just because of presence or absence of other criteria, unless it is life-threatening. The participants will be a heterogeneous group with respect to their characteristics. Once allocated to treatment group, patients do not necessarily receive the same treatment. They have the freedom to move to other way of treatment also. So there is freedom, flexibility given the treatment protocol, and it is tailored to the patient's need, which is not the case in exploratory trials. In exploratory trials, there is a very rigid protocol which is set and it has to be followed 100%. There is no question of protocol deviation, whereas in pragmatic trials, based on the need of the patients, there is a scope for tailoring the treatment to the patient's needs, and that is the main hallmark of pragmatic trial. And that is why if the intervention passes through this pragmatic trial, it can very well be practiced in the routine setup. But asking an appropriate research question is very important. The study design should match the clearly defined research question. If you are interested in evaluating the benefits of a therapy in everyday practice, then you need to use a normal clinical setting and a pragmatic design. So whenever the question of routine therapy in a routine practice is concerned, pragmatic trial is the best design. Moreover, it allows you to have a bundle evaluation of the bundle care also. For example, there are a lot of bundles, sepsis bundle, in ICU setting you have a catheter bundle. So the pragmatic trials allow you to test the efficacy of the package or the bundle as a whole, although you cannot study the contributions of individual components. You generally would compare the effects of the package or the bundle with another treatment or other alternative. So evaluating the entire bundle is a very unique situation for a pragmatic trial, and which is quite useful in the practice. You generally require a larger sample because of the possibility of the bias. To compensate for that, the sample size has to be bigger in a pragmatic trial. So it will be a larger sample, recruiting from a wider population and a more heterogeneous mix of patients. But then recruitment and randomizations are still there for both the type of trials. Randomization is very important for both the trials to maintain a good validity. A lot of problems come up with respect to ethics committee and pragmatic trials. Since pragmatic trial is a new kind of evolving trial design, many ethics committee may not be well versed with the functioning of the pragmatic trials, and the researcher may encounter some issues with the ethics committee. For example, the information given to the subjects is quite minimal because the interventions are already known to be safe to the patient. So there is no need to give elaborate risk assessment, or unnecessary details are not required in the consent information sheet. But ethics committee may not agree to all this condensation of the information sheet. The waiver of consent is a possibility in a pragmatic trial, but ethics committee may not agree with that. And the scientific committee may have objections for not having blinding also. And there can be difference of opinion between the researcher and the ethics committee with regard to the minimal risk or harm and the compensation. The researchers may feel that since these are established treatments, there is no question of compensation because these are established treatment modalities. But then there can be some difference of opinion. Since the treatment protocol is flexible, the scientific committee may not agree with that because most of the scientific committee will be still looking into it as an explanatory trial where protocols are rigid. So this flexibility of the protocol has to be understood by ethics committee, so that the ethics committee members should be well versed with the pragmatic trial designs. Some of the examples where pragmatic trials can be used in a routine practice are acute coronary syndrome and percutaneous coronary involvement in the real world assessment. Newer inhalers versus standard treatment in asthma in a real-world scenario. Treatment of severe sepsis with the empirical treatment where we don't have the identification of organism and given as a bundled care, whether it's better compared to the conventional treatment arm. What about de-escalation? Because often we don't have culture support and it will be empirical decision, and these are the situations where a pragmatic trial will be useful. Statins for primary prevention in the primary care, not just in the hospital, will be a good example of a pragmatic trial, similar to aspirin in primary prevention. And fluid therapy based on IVC collapse in sepsis patients to prevent AKI could be another example of a good pragmatic trial. Pragmatic trials have to optimize the sample size and randomization because they have some inherent weaknesses because of which the bias may be there. So the conventional small samples may not be sufficient. The limitations of the pragmatic trials are overcome by having a larger sample size and going for appropriate and good randomization practices. When should you use pragmatic trial? Whenever you want to compare established treatments or procedures or the drugs, you can go for pragmatic trial. Effectiveness of alternative medical practice is to be evaluated, can be done by a pragmatic trial. Quality improvement research, bundle packages or cares are the ideal ones where pragmatic trial can be done. Evolving emergencies or pandemics are ideal situations where pragmatic trial can give a lot of answers. For example, recovery trial. In the beginning of the pandemic, we did not know whether hydroxychloroquine works or not. Based on the observation studies, many guidelines suggested to use hydroxychloroquine for COVID-19. But then, when it was done in a randomized clinical trial, we knew that it was not working. But then, if we waited for an explanatory trial, it would have taken a long time. Recovery trial was a classic example of a significantly pragmatic trial and which included very minimal inclusion criteria and broad-based patient inclusions and very fast randomization based on web eligibility criteria, and all that led to very important discovery of utility of dexamethasone. So recovery trial was a classic example of a pragmatic trial coming out of as an innovation in the time of crisis. Advantages are easy to design, less funding requirement, can be done as part of routine treatment care, consent may be waived in special conditions. It is an effectiveness analysis. Subjects are not experimented because this is already established treatment modality. So this is research without experimentation. It is ideal for research limited settings. But there are some disadvantages also. It is not for new drugs or devices because they have to go through regulatory processes. Large sample is required. Convincing institutional research board is a challenge. Convincing publishers and funders is a problem. But having said that, of late, a lot of pragmatic trials have been published even in high impact journals like New England Journal of Medicine. And there is a risk of failing to identify a benefit in a core ideal population, subgroup of population, owing to a lack of benefit in a broader average population. So this dilution is one of the challenges. Pragmatic trials are easier for frontline clinicians to operationalize. They are easier for real world patients to join the trial. They are easier for the public to extrapolate the results. For the scientist researcher, hardcore clinical trials are okay, but for a clinical researcher, meaningful pragmatic trials are very important. Observation studies are easy but worthless. Explanatory randomized control trials are rigorous and demanding. In between, for a practicing clinician, are the pragmatic trials which are innovative, gentle, manageable, and purposeful. Thank you very much.
Thank you. That was wonderful, Dr. Animesh and Dr. Chakrapani also. And what we could see was that Animesh was trying to tell us the hierarchy of evidence which can be generated by various types of studies. And but however, he made it very easy for all of us to understand and get attracted towards collecting our own data and see to it that in which block it fits and how we can analyze it ahead. And Dr. Chakrapani's presentation was in my opinion, I found it to be a great relief, because for you to come out with evidence, generation of evidence in any studies, people always look at those randomized control trials, which are at the highest place in hierarchy. However, we know how difficult it is and how important it is to register the trial. And the process may not be very easy. And everybody may not have an access to a good team to help you with all this. I find that pragmatic studies would really be giving you a win-win situation of doing a wonderful study, collecting a great data, and still generating evidence as good as RCTs, but keeping you free from all the hindrances that you come across when you want to go ahead with RCT on your own, if it's not designed by somebody else. So that was great. And I know the audience is very eager to hear the panel discussion, and they must have already put in their questions also to the panel. I would request Dr. Animesh Jain to go ahead with the panel discussion. And before that, I thank the team of CCI, Dr. Krishna, Dr. Narayana Pradeep, Dr. Ravi, Dr. Atri, and one doctor, I'm not recollecting the name. And we are very thankful for them to bringing up these innovative topics in the interest of the younger pulmonologists as well as all younger practitioners. Thank you. Dr. Animesh, the stage is yours.
Thank you, Radha ma'am. Am I audible?
Yes.
Okay. Right. So thank you. And let me take the pleasure of introducing the panelists today. So we have Professor Vishnu Sharma, who is professor and head at the AJ Institute of Medical Sciences, Mangalore. He heads the Department of Respiratory Medicine. And we also have Dr. Dinesh S from Bangalore, who is the director of Department of Pulmonary Critical Care and Sleep Medicine from the SCG Hospital as well as the Bosch Hospital in Bangalore. So welcome to the panelists, the others you have introduced, and Radha ma'am, of course, thank you for being with us. So we'll move on, and I think our the presentations have generated some interest. We've started getting questions. So let me first ask our panelist, Dr. Dinesh. Dr. Dinesh, could you please suggest some broad areas of research in pulmonology? This would be just the starter, and then we will move on to the questions as well. So can you please suggest some of the broad areas?
Good evening, everyone. And I thank the CCI family for considering me in this panel. And yes, it's a very interesting topic to be discussed, and a very important topic as well. Yes, there are a few specialties in which we can work on, and the work needs to be done. One I feel is the immunology and the cancers, and of course the treatment part. In immunology and cancers, I feel there is a lot of overlap which occurs, and so we can touch upon a lot of research there. In fact, I have personally started on SLE and rheumatology along with my fellow rheumatologists. And in the cancer, I've also started working on certain markers apart from the regular like the EGFR and PGLF and all that stuff. So we can, and also the other broad areas which we can look into is also the infectious diseases, where right now, apart from COVID, I think we are also seeing a lot of interesting infections, and both community acquired, hospital acquired with resistance. And the newer antibiotics are not in the horizon, so probably that research will also help us.
Right. So thank you, Dr. Dinesh. I think I'll ask a next question very importantly. I thought we'll take it later, but see, for any kind of research, many times some of them are academic, yes, but even then we require some money. The funds are important. So I'll turn to Dr. Radha and ask if there are some kind of sources that we can tap. Are there some kind of opportunities for funding from particular agencies that she could enlighten us on? So Radha ma'am, could you please tell us about some of the sources or some of the funding agencies which could fund research in pulmonology? Ma'am, you're muted.
Yes. Whenever we talk about funding, I know it's a issue which is very important and very difficult to take over. If we talk about from the pulmonology point of view, and I'm more well versed with the funding for TB research, we have ICMR, then National TB Elimination Program. So CTD also funds research in tuberculosis. Then we have TB Consortium also. And the beauty of TB Consortium is that they not only support the research in TB in the private sector, but it is also for in the public sector, but it's also for all private sector as well as various NGOs who want to take up research in tuberculosis. And then even your local DMER may be there. They have also facilities for research grants. Then there are various industries now which are coming up and giving grants for research. Then apart from that, it's very important for all of us to note that we always think of research in medicine, but let us not forget that most of the research in medicine comes from basic sciences. So you need to have alliances with different people who may be physicists, who may be mechanical engineer, they may be electronics engineer, and so on. They may be environmentalists and so on and so forth. And COVID has let us know ki kitna we were in need of innovations, and we wanted them to come very fast for the betterment of the patient as well as for the healthcare personnel. So there are various agencies like Atomic Energy Regulation Board, Aeronautic Research and Development Board. So if somebody wants to take up some research on air travel and lung health, perhaps aeronautics research may help them. Then there is research in nuclear sciences. So if there are any research in cancer diagnosis, management, staging, treatment of metastatic cancers, perhaps they may be able to help. Then there is Defense Research and Development Organization, what we call as DRDO, Department of Atomic Energy, as well as Department of Biotechnology. And I have found that if this research is in collaboration with other scientists, doctors are not trained to apply for the grants. So they really do not know, and if they apply once and twice, and if they do not get, they may lose their interest or their initiative. But if you work in collaboration with other scientists, then you would know that they are well versed in writing for grants, and they may help you in also designing the question, research question, as well as applying to the relevant agency. Then apart from this, there are few grants which are in collaboration of our country with other countries. So there is India and Republic of Korea Joint Applied R&D program which gives funding. Then there is a DUSH funding which is a German research grant. Then Indo-French Center for Promotion of Advanced Research would give grants. Indo-US Science and Technology Forum would give grants. UK-India Education and Research Initiative is there, and then Global Innovation Technology Alliance. This is for individual, as well as country specific grants can be had for you can get. There's like TB Alliance and all that. There also you get good grants for country, and then they are then distributed to various stakeholders which take up that particular grant. Apart from that, even local engineering colleges or local technical colleges, dental colleges, these are also very good areas where you should explore collaboration and go ahead with your innovative ideas along with them. That's it, Dr. Animesh.
Thank you, ma'am. You've given us a very lot of information and also stressed on the collaboration aspect, and you came up with the research question. So my next question will be pertaining to research question, and I'll put forth to Dr. Chakrapani, who is a very avid researcher along with being a very astute clinician. So Chakrapani sir, could you please tell us that how do we convert our research idea into a research question?
Thank you, Dr. Animesh. Most of that has been covered by your talk itself, where you have outlined the flow of the research. As you rightly pointed out, it starts with the initial thought process or a clinical observation. That clinical observation has to be transformed into a research question, because the design, the way you collect data, the way you analyze that will depend upon the research question. So that's why the research question is very important. And often young researchers, young MD students simply say that they're interested in tuberculosis, or they would say they're interested in asthma, without specifying what aspect of that disease they're interested in. So in general, it requires someone in the field who has been seeing patients and who has identified a clinical problem. And from that problem, the research question should come, because ideally clinical research starts from the bedside, goes as far away possible to the laboratories or the libraries or the computers, and then comes back to the bedside. So that is the actual flow of the clinical research. So it should start with the burning issue in the practice, something which a senior person in the field has observed. Then that observation has to be narrowed down to a research question, and then it has to be transferred into clinical study material. So please don't start with the thesis by what is published already. Now, whenever PGs join in a department, they first go to the library and look into the published articles. That's not the place you must start. You must start from your own clinical problems, or problems which have been seen by your own seniors or professors in the clinical practice. The research question should start from a burning clinical thought process or a burning clinical issue, and then convert into research question. Thank you.
Can I add one sentence?
Definitely,
Dr.
ma'am.
Animesh?
Yes, ma'am.
So what Dr. Chakrapani meant to say was that if you have a statement like doxycycline is a useful drug in prevention of severe forms of COVID, if that is a statement, then it has to be converted into a research question. Does doxycycline help in preventing serious forms of COVID in a RT-PCR positive patient or any COVID infected patient? Now, that is how it would convert into a research question. And of course, the strategy of SMART applies everywhere.
Right. Thank you. And I think excellent, because Chakrapani sir has very rightly advised the budding postgraduates and the young people that start with not from the other end, but start with the clinical problem that you're experiencing, and so that will help us.
Right.
And so I really love that, sir.
Formulate a research question and then go to library to see whether there is any evidence or literature, either positive or negative, on that particular topic.
No, and I really loved it the way he said that it starts from the bedside, goes as far as the way possible, and then comes back to the that's the idea. Clinical research has to be like that. And thank you, sir. Thank you. Beautiful thought. And I think one more thing just to add from my 2 cents is finer. I think that's what we say. So feasibility has to be looked at. It should be interesting, it should be novel, it should be ethical, and of course, it should be realistic. So moving on, Dr. Vishnu has been patiently waiting. So sir, you won't be left behind. I would come to you now. Sir, I know that you're very much into this, you are very much into quiz and so many other things, but I'm asking you a different kind of approach now. So what are the tools that we require? Some of them I outlined, and how do we actually decide on the tools that we are going to finally use for our proposed research?
Basically, the tools will depend on what kind of research we are doing. So basically, we are collecting data. Research means data collection. Am I audible?
Yes.
Yes, sir.
So it depends what kind of research we are into and what kind of data we are going to collect. So most often what we require is maybe observations, surveys, questionnaires, or sometimes personal interviews, or in case control studies and other things, we need to have checklists. And we may have to do some experiments also in experimental studies. These are the basic tools.
Right, sir. So we can have, depending on what is my study question and research question and what is my study design, the tools will depend on that, simply put. And I think that's fine. So we'll move on to ma'am, Radha ma'am. Again, I know that you've had some experience and you've also, I think, facilitated workshops on operational research. And what I understand, I think TB operational research is one of your probably interest areas, if I understand correct. So could you please shed some light on what exactly is this operational research and how exactly we can go about? Does it require any particular training or is there any particular requirement? So could you please shed some light on that?
Yes. Actually, operational research is quite different from what we usually talk about clinical research. It looks into the process of a particular program or disease treatment protocols. And then we have to see into how best those resources can be utilized for the best possible delivery. So this is a research tool which is utilized to bring about improvement in performance of a disease control program. And that is why it's very, very relevant for tuberculosis. And as we all know, you may belong to any specialty. You may be a pediatrician, physician, a pulmonologist, a person from community medicine, even or from Department of Microbiology, or even surgery. Our national TB program has undergone lots of changes, and many of these changes which has come up is a result of not of clinical research alone, but also operational research which has happened. I would quote one or two examples for this. One is there was a question earlier, NTP proposed 3 sputum examination for diagnosis of TB. 3 sputum samples were taken. And then a study was done on performance of 2 sputum sample, that is 1 spot and 1 overnight versus 2 spot and 1 overnight. And when we looked into the data, it was observed that the data, performance of 2 sputum sample was almost equal to 3 samples, whereas the patient and the health machinery had to work a lot to get the 3rd sample, collect the sample and give reports. It also caused delay in giving reports. So now the policy changed to taking only 2 samples and then giving a report and deciding on the diagnosis of tuberculosis. This is just an example. Another one was in the correlation for diabetes and tuberculosis. And early intervention of diabetes led to better results for TB treatment, better outcomes with TB treatment. And hence now it has been incorporated that all TB suspects as well as those diagnosed with tuberculosis should undergo blood sugar examination. So these are small examples of operational research. So, and every year or almost after an year or two, there is a list displayed on the website of tbcindia.org of various topics where operational research is needed. So what you do is you look at the program and the way it is being implemented related with your field. Don't look into the whole program. Just look at, जैसे Chakrapani sir ने बोला, go to the bedside. Similarly, I would say you go to your own clinic, look into your own patients, look what type of services are being rendered and what is needed, or what type of the services which are being rendered, are they effective enough or not in the way which is needed? And if not, then why it is not so can be identified, and a rectification or corrective measure can be suggested, which would then come up as a policy. Then what are the trainings needed for operational research? Basically, all operational research done should be converted into publication, because once you publish this, it is going to affect the policy and bring about some changes in the norms. So it's very important that you make a publication out of this. It's going to be taken in the second part, so I'm not going to talk about it. Trainings are available for operational research and various workshops are being conducted. But even if you are not a part of workshop and even if you are not trained, if you approach the local person, for example, I may quote an example right here that you have a good team of Dr. Chakrapani and Dr. Animesh here, and they would be happy to mentor anybody and everybody from their own area, like Mangalore ka koi hai, Karnataka ka koi hai, and they approach them with the problem that they come across and they want to deal. They would be mentoring, and I don't think operational research is very difficult. Only important part is you identify what you want to do, form a research question, and then go ahead in which way you are going to approach that question scientifically and methodically to come to a conclusion. That's it.
Thank you, ma'am. Very elaborately you have explained, and though in very little limited time, but I think you have still explained. So thank you. I think that gives us a good idea. Next, I would ask Dr. Dinesh, since we are talking of different types of research. So I would ask Dr. Dinesh, see, a lot of the sponsored clinical trials are also done. How is the sponsored clinical trial different from the academic research that is going on in some institutions where we have the academic setup? Is it the same? And we can have sponsored trials even in academic, but then is it different from academic trial or academic research?
You are
Dr.
muted.
Dr. Dinesh, you need to unmute.
Okay, now am I audible? Hello?
Yes, you are. Yes, you are.
Yeah. See, right now, I was just saying that I'm a part of both sponsored as well as academic clinical trial, where we run a PG program in our institute. I'm also a professor in the other hospital. So the sponsored trials sometimes help us in a lot of other ways, in monetary ways as well as the other ways. But the academic trials is a self-driven one, as far as I consider it. It's like, your aim and your inclusion, exclusion criteria, everything depends on what you want, as well as the endpoint and efficacy. Whereas a sponsored trial, sometimes it might be driven by what the sponsors would want to. That's my feeling. I know some people might disagree with me, but from whenever I was approached for a few sponsored trials, they would want the end results saying so and so. But at the same time, if you put your foot down and if you're a good researcher and if you have your views intact and, speak to them, I'm sure that would also be negated. But nevertheless, both trials will have the pluses. And hello.
Yes, please. Yes, Dr. Dinesh, we are able to hear you. Are you done?
Hello. Yeah. So I was saying that yes, the clinical trials, both academic and the sponsor trials, are equally good. But I would prefer to do more of academic trials.
Right.
Yeah.
Thank you. Thank you. Any other panelists would like to express their views about maybe Dr. Chakrapani and Dr. Radha?
I would like to say something. I have not done any of the sponsored trial, but what having worked on 2 or 3 ethical committees as chairman, I have seen many trials coming. And few of the advantages, if you are honest enough to conduct a study in a very ethical way, and it's very important that there is no violation of protocol in these studies. That is the first important thing. And secondly, many patients are benefited because various investigations are offered free of cost. There are the patient can opt out of the study anytime, and if it is explained properly, they do really have this authority with themselves. And even the costliest drugs, and especially if there are studies of bioequivalence, and at that time the patients are benefited because of many of the costs. And most importantly, if you look at it from the researcher point of view, even if these sponsor studies, almost all of them are RCTs, but you learn the method in which you should go ahead with study. You look at the protocol, you read the details, and it also helps you to design various academic studies in your work area. That is my personal opinion.
Dr. Animesh?
Yes, sir. Yes, sir. Please go ahead.
I would like to add a couple of points. Sponsored trial is a contract work. Somebody else has designed the study. It is their idea, their thought process. You're just executing part of it. So it does not give a significant amount of intellectual satisfaction to the person who is doing the study. Although I should admit that most of them are very well designed studies. Whereas investigator-initiated academic trials are your own studies. You have started the study, it is your idea and you are doing it. So there's much more intellectual satisfaction with the academic investigator-initiated academic studies, but then it's quite difficult to do it because you require a lot of funding. That's the basic difference between the two. And regarding registration with the drug controller, since the sponsored studies are for commercial purposes, they have to be registered in the regulatory trials processes, whereas investigator-initiated academic trials need not be registered with the drug controller because these are not for commercial purposes. But then they have to be cleared by the ethics committee, and if there is a new formulation which is being used by the investigator, the information has to go to the drug control, and within a month they will get the reply. If not, it is deemed to be accepted. The next point is regarding compensation. In a sponsored clinical trial, the ethics committee will scrutinize all possible harms and the compensation in case there is a harm, and there should be an explicit and very clear-cut document of insurance for a sponsored clinical trial. Whereas for investigator-initiated trial, either the institution or the individual has to guarantee in case there is a research-related harm or injury for which there has to be compensation. Compensation will be then both of them. But in a sponsored clinical trial, the sponsor would have insured, and there has to be a clear-cut document of the insurance certificate. In investigator-initiated trial, either the institution or the individual investigator will stand guarantee for the compensation should there be a research-related harm or injury. Thank you very much.
Thank you. Thank you for adding those points, sir. And I think if it's either of them, of course, if it's a sponsor initiated, correct me if I'm wrong, sir, that will be anywhere required to be registered in the clinical trial registry. And even if the academic trial is of any kind of interventional trial, then I think CTRI registration has to be done.
CTRI registration is a must for all the studies.
For all the trials.
Yes.
Yes.
Yeah, for all the trials, CTRI registration is a must.
Yes.
Yes.
But whereas sponsored RCTs have to be registered in the drug controller also, because most of them are new drugs, so they have to be approved and registered with the drug controller also.
Absolutely. Yes. Thank you for clarifying. Sir Chakrapani, sir, I think your talk has evoked a lot of interest. So there is a question from Dr. Govinda Narke from Pune, Maharashtra. He asked, can we have the pragmatic trials in pulmonology in primary care setting?
Thank you very much for that question. And Dr. Radha Madam has initially itself pointed out the difficulties of observational studies and the need for the randomized trials in the clinical practice to generate evidence. Traditionally in India, or for that matter, most of third world countries where conducting a randomized control trial is difficult, researchers have mainly focused on observational studies and to generate observational data. No doubt they are important and they are required, but then to generate evidence, these observational studies are not sufficient. We need to have clinical trials. So that's where these innovative pragmatic trials are coming to our rescue. Some of this, as you would have seen in my presentation, the pragmatic trials are ideally suited for the primary care. In your routine practice setting, you don't require a big setup for that. Wherever you are practicing, just have to have a good research question and then have a decent protocol and get it cleared through your ethics committee. Then you can run the next pragmatic trial. Some of the examples I can give you. For example, if there are two methods of inhaler devices, now one center can do one method of inhaler technique for their patients. Another center can, this is called cluster randomization. One hospital is randomized for one method of inhaler technique. Other hospital is randomized for other technique, and then compare the data. So that is one of the easiest way of doing, and this is done in a routine practice. You don't require any big setup for that. And look into the repeat admissions. So this is a hardcore endpoint, repeat admissions for worsening of the asthma. This is one example. Other example could be effect of mask and respiratory infections. You can see in your own practice, people who wear proper mask and then compare the others. It can either be observational study or a pragmatic study. Both can be done depending upon the amount of masking adherence that is seen. Other example would be the traditional guideline is inhaler followed by tablets, but then there is always inhaler inhibition in the Indian context. So we can have a pragmatic group, one tablet followed by inhalers, other one inhaler followed by tablet, and look into the outcome. So this is not unethical, because in India we see both of them are being practiced. So in pragmatic trials, you compare accepted routine practices one over the other. So these are some of the simple examples that come to my mind with regard to pragmatic trials in the routine primary care.
Thank you, sir.
Next one would be simple health education and asthma admissions. Now, it is difficult to do a proper randomized controlled trial with health education because blinding is not possible there. In one group, we are giving proper health education regarding the inhaler technique. Other group, it can't be blinded. But then pragmatic trial is the ideal way of solving this issue in your routine practice, and see how many of them come back with the repeat admissions for worsening of the asthma. One more example could be alternative medicine. Alternative medicine can best be experimented in a pragmatic trial, because this comes as a bundle of care. Most of the alternative medicines, they're not one medicines, it's a group of medications, group of practices, and that can be compared with the modern medicine. Only thing is, you must have a subject expert who is an expert in that field as a part of your study team. So these are some of the examples which come to my mind as far as pragmatic trials in pulmonology are concerned. Thank you.
Sir, thank you. You have given us such a range of and gamut of examples, and that's really helpful, I believe. I'm sure that Dr. Narke has got a good idea of that. Radha ma'am, I'll ask you this question. I think probably you may be the best person. Otherwise, I'll open to another panelist. This is from Dr. Aditya Parihar from Nagpur, your place. So that's why I'm asking you. And the topic also, any comments on occupational and workplace related research?
Yes, I think, can you hear me? Yes. I think
Yes.
there is a lot of scope for occupational health related research, and especially areas where we have identified areas where some people are exposed to a particular occupation. For example, there may be mines, then, or there may be people involved, like now we have seen in COVID that we have seen people working in sanitation areas. It's also an occupation which exposes you to a lot of infections as well as other pollutants in their work environment. There is a lot of scope for research. It is for the basic doctor, as Dr. Chakrapani also pointed out and giving examples, that it is for the healthcare worker or the doctor to identify that which type of ailments are common, or which type of ailments are there but are not brought forth, and what can be done to detect them at earliest. That can be done, and there is a lot of scope for research. And I think if there are facilities available to assess the patients, apart from questionnaire, the quality of life related questionnaire, what type of exposure they have, what equipments they wear to prevent exposure to the environmental pollution or other pollutants which may be there in the work environment, that can be studied, and research can be done. There is a lot of scope for this, I feel. In fact, I have seen somebody doing a research on identifying some proteins in the blood, of course, serum, which would predict earlier development of deafness in those who are working on drilling machines. I do not know whether they have come up with the kits for diagnosis and whether it has been marketed ahead. But like this, there are lots of areas where research can be done. And that is why I said that collaboration is very important. You may have lots of ideas, but you may not have ways to execute them. So if you have somebody who would not only do your hand holding during the research or for the research, but collaborative, where there are basic scientists involved, so they have a lot of infrastructure in their laboratories, and that would be one great help, and it cuts down on the cost also.
Thank you, ma'am. Thank you. That's a very good point, and collaboration. I'll come to that again, but I'll ask Dr. Vishnu, sir. I think, as I understand, as I told you, he's quite interested in some things, and I also somehow have a feeling that he's a person with gadgets. Of course, Chakrapani sir is another one who's very much keen into some of these iPad and other things which he uses for academics. So, Vishnu, sir, could you please tell us that how can we utilize these gadgets, whether it's tablets, gadgets, computers, in research, and what is the utility of probably these things in the research, maybe day-to-day research, because nowadays almost everybody has, and then we are quite well versed with certain things, but not for research. So could you please throw some light on that? Sir, you're muted, I think.
Yeah. Research basically means gathering data. So with these gadgets, gathering data and analyzing data is much easier than it was earlier. And we have got a lot of softwares also for generating questionnaires, and then within no time we can distribute it across and get the feedback. So things are much more easy with the gadgets. And then for analysis also, various softwares are available. Only thing is we need to know which one to use and when.
I would like probably Chakrapani sir also to pitch in, because I know that he uses, and he also is quite familiar with certain things, including mentally he's taught many of us, including the postgraduates he takes sessions. So, sir, could you also throw some light on this question?
Dr. Animesh, Mental is a very useful software, and I would recommend it strongly for all the postgraduates and junior researchers to start using it from the beginning. And many people think about this bibliographic software at the end of the study. When you begin the study, as you are collecting all the important papers in that field, immediately read them, mark your notes in that, highlight whatever is important, make your own sentences and store them in the Mendeley software. And once even for writing the protocols, use the Mendeley. And then once you have your data, analyze it, and then while writing the paper, then again use Mendeley. So it is from beginning till end. And this is something which is not understood by many of the PGs who think about this kind of software only at the end of their work. So start using them from the beginning. And for statistical analysis, of course, nothing to beat SPSS. And you don't have to be a hardcore statistician to do analysis of your research. I would suggest that every researcher should have some basic idea of SPSS and start using them. They're very, very easy. And you can have even a few hours of online course, and then you can do your basic statistics. I'm not asking everyone to become an advanced statistician in their research. That's not required. But unless you have some basic working knowledge of the statistical softwares, you will not be able to derive maximum out of your research. When you give your data to a statistician without much, who doesn't know much of your study details, they may or may not come out with the appropriate results. But if you know the fundamentals of statistics, you can relook into your own data and come out with meaningful outcomes. So to extract meaningful outcome of your research, you should have some basic information of the statistics and statistical softwares. Thank you.
Thank you, sir. Thank you. You touched on a very important topic, and I'll come back to you on that. So let me first ask Dr. Dinesh, since you said about this Mendeley and other things, and Dr. Vishnu said that this gadgets. So Dinesh, sir, could you tell us how can we go about building capacity of people in doing research? What would be your mantra or your advice to people? How could we see to it that at least they have the basic fundamental idea as Dr. Chakrapani was talking?
See, basically, like what Dr. Chakrapani and Dr. Vishnu and Dr. Radha had already told, it's basically until unless you see the patient's bedside, start off, the idea starts from there. You'll have to get motivated. You'll have to be like a 3-year-old child or 5-year-old child who keeps asking questions. Why, where, when, what? Until unless you keep getting those thoughts in your mind, you will not be able to do the research. So the more you spend the time, the more you see the patient, it's in the bedside, and the more you ask the questions, even if it is already a framed guideline, I think you should question and then start off from there. Only then you will be able to have a realistic approach. And of course, you will also have to collaborate with the other specialities or other individuals like I think Dr. Vishnu and Dr. Thing would also specified that we need the collaboration, like, it could be a biomolecular engineer or anyone, who can help us in the research. So we'll have to keep constant touch with them, constant interaction with them. So the interaction and the conversations will take it forward. Otherwise, what will happen is, I've seen people who just get stuck. Okay, this is the guideline. Let us not do. Even the highest of the individuals, sometimes you're even pulled up why this was not followed or why that was not followed. You should always question and take it forward from there. And the other motivation thing which I would say is, they should motivate each other. The motivation starts off from the PG levels. I think the approach to the PGs should be like, we are going to be back of each other and also discuss that. And, you take up this topic, I take up this topic, and those pros and cons debates among themselves. And that is when they'll also start getting ideas for the research. Otherwise, what will happen is they'll just get stuck with only the framed protocols, the framed bundles, and so on and so forth. So I would say that, and actually a few of my PGs have been doing this, and they've come up with the brilliant ideas. And not to put down the undergraduates. Even in the undergraduates, sometimes when they're doing the physiology or even the biochemistry, even they come up with the ideas. So we should also encourage them and take up their ideas. That's why you should always discuss, and also the PG levels to also discuss with the undergraduates as well. And as long as the interdepartment and intra-department discussions occur, I think that's the way forward.
So what I gather is discussion is the mantra, and then collaboration. Discussion and collaboration. And of course, we should not think that, even if it comes from undergraduate, postgraduate, so we should listen to them and take these ideas. And further to that, I think, as you said, we have to, talk to each other, peers, and I would try to also say that probably even recognizing the fact that, yes, this is something probably I need to know. You said motivation, but that first step I would say is, I should say that, yes, I don't know this and I'm interested in knowing this. And that's where I would want to probably go forth and learn about it. So that's what I would probably also add.
Absolutely.
Yes. So Chakrapani sir, you just talked about, statistics. I'll come back to you. I know that, you do a lot of your statistics yourself and you are well versed with some of these things. And in fact, sometimes some of these things you teach us. So is it very important for us to know, and how we go about the sample size calculation? How do we determine, or what is the information, at least if not yourself, what is the information that I should have when I go and meet somebody for calculation of statistics, sample size specifically?
Sample size calculation is a very important part of the protocol. And often young researchers find it very hard to understand why ethics committee is worried about the sample size. They say, I'll study about 30 or 40 cases. What is wrong in that? Now, the point is to get a meaningful outcome of a statistical significance with the sufficient power for the study, there has to be sufficient number of subjects recruited. Otherwise, if the sample size is small, for example, if the actual sample size required is about 200, you do only 30 subjects in your study, then the result from the study may not be applicable or may not be true. You may come out with this statement saying there is a difference between the group, but statistically not significant. In fact, if you got a proper sample, there would have been statistical significance. To avoid all these complications, you must have a rough approximation as to what should be the number of subjects required in the beginning itself. That helps you to look after the finances required. That also helps you to look into the logistics that have to be arranged for the expected samples. So sample size calculation is an approximation. It is not an actual number. It is a big approximation because there are a lot of assumptions that go into the calculation of the sample size. So don't get worried about a specific number. It is just a rough approximation as to how much should be the beginning number so that you can plan for the finances, logistics, or the other requirements. How do you calculate that? There are very complex formulae based on the study design or study type. So we're going back to the previous presentations, study thought, study question, then with that study design, then along with that different types of sample size calculations. You don't have to worry about exact methods. Either go to statistician or these days many online calculators are available. You just have to put into Google. For example, whenever I have to do sample size calculation for comparison proportions, I just enter into the Google calculate sample size calculator for comparing proportions, and immediately you will get many calculators. Key in your expected numbers. What the expected numbers are very important. You may have it from previous studies or your the best scientific guess. So it need not be a precise number. It is if the data is available already from other studies, use that number. But otherwise, you use your best scientific guesstimate and then enter those numbers. Then you'll get the sample size. And for most of the descriptive studies, you require to give the expected mean and expected standard deviation, because if the standard deviation is wide, you require larger samples to have a meaningful difference. If the standard deviation is small, you require a rather small sample size to work around. And if the expected difference between the two groups is very small, then you require bigger sample. So don't get confused. Ultimately, you key in those expected numbers, and then based on the study design, go for the appropriate calculator. You will get the sample size required, and then add about 10% for dropout, and that gives a rough approximation of the sample size required. As you go along, you may have to change the sample size. As I told earlier, this is based on scientific guess, which may not be the final outcome. So when you go along your study, if you find that the outcomes are different from what was expected, the sample size may also change. So you just have to tell your ethics committee that based on my observation till now, I would like to change the sample size and give the reason for that, and the sample size can be changed. So sample size is not a perfect number. It is the best scientific guess to decide the required number. The ethics committee wants to know about it because if you take too less a sample, it's unethical because you may not get the proper outcome. If you take too big a sample, it is again unethical because every research involves certain amount of harm, and you are exposing too many people for that unnecessary harm. So that's why getting that magic number is important, and make use of these calculators from the web, or meet a statistician, give the precise numbers required for them, and only then they can calculate the sample size. Thank you.
Thank you, sir. Thank you. So that's very nice, but I see a question popping up also immediately. So this comes from Dr. C. Vijay Kumar from Hyderabad. He talks about many studies even on COVID have published data with 15 cases and 30 cases. How is it decided then? So any thoughts or comments on that, sir?
If it is just a descriptive observation, then there's not much of a sample size requirement because you're just explaining what you're seeing. But then when the sample size is small, if the confidence interval is very wide, then you can't hardly have any meaningful outcome and interpretation out of that. So just because it's published, it does not mean that that's the correct way of doing it. During COVID time, we have seen that with so many journals coming around, and some of them did have accepted even poor quality studies. So just because they have been published doesn't mean that they are of good quality. I still go by the fact that before you begin, have some approximate numbers based on the previous experience or your expectations, then decide the sample set, then proceed, just to avoid unnecessary wrong interpretation of the data.
Yes, thank you, sir. Thank you. So here is a clinician who's talking about sample size and he's telling you about these things. I'm sure that, it should motivate some of. So as you rightly said, sir, and the confidence interval you talked about, and the generalizability will not be good if we have a very small sample size. You rightly said that, sir. So since you mentioned, sir, I'll take another question with you before I ask another question to our panelists, and probably in a couple of minutes we'll wind up. It's already 9:30. But I want to take one question because you mentioned, and I think Dr. Radha also mentioned. So this ethics committee, now many of us or many of our colleagues and researchers are terrified. They feel that, ethics committee, it's some kind of an ordeal, or maybe it's something, a roadblock. So, sir, could you just simply, I know that you've been part of many ethics committees, also a co-chairperson. So I would like you to just guide us how exactly, or how do we proceed, and what are the requirements for submission, or how do we go about submitting to the ethics committee and complying with the requirements? Could you just quickly tell us, please?
Ethics committee and researcher, it has been a cat and mouse game. I have been on both sides. I've seen I've been a researcher and facing ethics committee. I've been on the other side also. I think the communication gap between the two parties should come down or should disappear. Ethics committee should not behave in a very high-handed manner, thinking as if they're like a Supreme Court. It's not. Their job is to just look into the document and see whether they are fitting into the criteria laid down by the ICMR document, and then clear it if it's appropriate. Now, the ethics committee functioning is not subjective. It's not subject to interpretation by each member. It is as per the guidelines given by ICMR. So the investigator, it is in the best interest for the investigator to go through these requirements and then decide, prepare the protocol. And ICMR has come out with detailed documents. For example, if you click ICMR ethics forms, you'll get a website of ICMR bioethics unit, where they have clearly laid down various forms required for ethics committee. And if you follow these forms, then your ethics committee meetings will be much more meaningful and fruitful. So I request all the investigators to go through this checklist, which is given by the ICMR. And these are the standard format on which most of the ethics committees are expected to function and discuss the protocol. And the requirement of the information consent sheet, explanation of the harm involved, the informed consent process, everything is laid down very clearly in this form. And if you comply with this form, then the question of rejection is much, much less. So please go to the Google and click in ICMR ethics and forms, and then you'll go to the site ICMR bioethical unit, and there are various forms given based on your study type. You can download the form and prepare your protocol as per the requirement for those forms.
Thank you, sir. Thank you. And as you rightly said, I know that you've been on both sides, so you are probably the right person to talk about it. So thank you. We've been talking more about these research and then academics, but I want to bring in another perspective. There are people who are completely into private practice, or they are consultants. They're not attached maybe to sometimes an academic institution. So I would like to get some idea from Dr. Vishnu that how can we actually have the consultants and private practitioners chip in, or maybe say contribute to the research and evidence generation so that can change practice. What can we do? Some thoughts on that, sir.
Yeah, main thing is to collaborate with others, because a busy practitioner may not be able to do all these things himself. So try to collaborate with other researchers. That's the first thing. Second is generate data. Now with the software, feeding the data is rather easy. And a private practitioner can always, as Dr. Chakrapani has already pointed out, doing a pragmatic research is rather easy. So that is how probably a private practitioner can go about with the research.
Dr. Animesh, can I contribute something?
Yes, sir. Yes, sir. Sure, sir. Please.
With the pragmatic trials coming up in a big way, there is a very important role for associations. For example, CCI, can be the nodal point for pragmatic trials. It can have a subcommittee of clinicians who prepare protocols and ask their members to implement in their practice, or for that matter, IMA or API. API, various chapters are there. Each city can have their own API group, which run some of these pragmatic clinical trials. And when it run through a group, it always has a lot of potential. Numbers are wider. There is a wider group of patient population, and that gives more credibility for the study. So it may be a bit difficult for individual practitioners who are not at all initiated to research to start pragmatic trials immediately. But organizations like CCA or IMA or API can develop their own individual sites for pragmatic trials, develop research questions, prepare protocols, and then ask the members to implement it. And then that can be a very good source of clinical information, meaningful information.
Sir, I think that's an excellent suggestion, wonderful idea. I'm sure that the leadership of CCI will definitely, we've been having some discussions in pre-webinar, and I'm sure they are planning for some, and there will be a next webinar, there will be a big announcement coming up. But I'm sure that this idea is very, very important, and I'm sure that they will take it up, knowing that how dynamic they are and their leadership is. Sir, since many times this word has come up, and I know that you have one person, and I have collaborated with you, and you collaborated with many others, including NITK Suratkal and other places. So I just wanted, before we wind up, one quick idea on how do we go about this collaboration with other departments, other specialities, out of medicine, out of healthcare. Could you just shed some light, sir? Give some idea and from your experience, Chakrapani sir.
Research is not a solo job. As clinicians, we perform very well in our individual capacity as clinicians. But when it comes to the question of group activity like research, we fail because we don't collaborate properly with others. Collaboration with basic scientists, as has already been discussed earlier, is extremely important, quite rewarding. And collaboration with the nearby institutes of maybe engineering colleges or other dental colleges will give you a lot of opportunity for meaningful research. Especially if you have got central institutes nearby, you please approach them because they have got a lot of access to fundings and their projects get cleared very easily by central funders. So as a private practitioner, you may not be able to tap the central government funds, but if you go through a central government institute which is in your neighborhood, and if they collaborate with you, there's a very high chance of success when you have such collaborative projects. The other point is international collaborations. If someone is approaching you with from international for international collaborations, if it have a proper MOU and if it is cleared by ethics committee, please grab it because most of these international collaborations yield a lot of good papers. And Dr. Animesh and we were working together on malaria project, and at least about 5 or 6 high quality publications have come out through this collaboration. So most of the international collaborations will yield good amount of publication in highly cited journals. So go for international collaborations or at least collaboration with central institutes and go beyond your own discipline and go to basic scientists and also to other fields like engineering colleges or dental colleges where you'll have good meaningful collaborations and good meaningful research projects.
Yes, thank you, sir. One thing I think I'll ask you and then probably chip in also. Dr. Kasim Resivi from Kerala, Mallapuram is asking, any free software to enter and analyze data? So what's your experience?
I don't know much about that. Maybe Dr. Vishnu Sharma can throw some light on that.
Dr. Vishnu?
Free software to enter and analyze data. Sorry, no idea.
Sir, EPI data is, see, SPSS is paid, of course. There is a version which is free trial for 15 days, and some of our students use it, undergraduates, but it's not free otherwise. Licensed version, of course, cracked versions are there, but if you're looking at a genuine software, no. So, but 15 days trial is there. Other than that, I would suggest that, EPI info is there, EPI data is there for certain specific purposes, which is free, WHO site is there. So these can be utilized. And there are some more freewares which are there, which has its own uses as well as limitations. And those are there. We can probably, come up with a list and share that. So that's So I think we've had a very fruitful discussion, and we are already 9 minutes ahead of what our closing schedule was. So before we close, I would like to ask each of the panelists to give pearls of wisdom to the participants, to the audience, and that's how we will close. So may I start with Dr. Dinesh first, and please tell us maybe one line or maybe just a couple of sentences just to close this, and what's your message for the audience?
It's a wonderful panel discussion, and I'm sure many of them with the panelists benefited from this. My key mantra or my key word is discuss, assess the patient, and keep asking yourself why, where, when, what. Be a childlike approach to all the clinical problems or whatever it may be. Your ideas will be generated and it will be contributed efficiently until and unless it's a teamwork.
Thank you, sir. So discuss, collaborate, and be a child. That's what.
Yes.
Right. Thank you. Vishnu, sir.
Yeah, I thank CCI for the wonderful opportunity and a lot of insights into research. So collaborating with others, I think, is the easiest way out and the best way out for a busy practitioner for research. As Professor Chakrapani has rightly pointed out, how the associations can come out, because now it is multi-center collaborations, which will generate a lot of data in a country like ours. And there is a lot of scope for clinical research, because the amount of clinical material what we have, I don't think any other country will. I think our associations should come forward with this idea and incorporate and then guide the members. Thank you.
Thank you, sir. Chakrapani, sir, over to you.
Research and practice should go together. And we have been thinking that they are two ends of the spectrum. Not really. They have to go together. And we should do research to enrich our clinical practice. Most often, research is done for publication. Publication should be the byproduct, not the end product. The end product should be solving one's own clinical issues with the patients and solving one's own clinical curiosities. So that should be the reason for doing research. And pragmatism is the way forward. And as has been pointed out, coming together in associations and being pragmatic will give us a lot of improvement in our clinical practice, and also as a byproduct, good amount of publications.
So thank you, sir. I think, again, you're saying coming together, collaboration, that's one of the key words. And of course, you've also stressed on the role of these associations, professional associations like IMA or API or CCI for that matter. And I think they have a role to play. I just got a message. Dr. Radha had to leave for a medical emergency. She has to attend. So she is not here. She just left a couple of minutes back, and I've just got a message. But anyway, ma'am was there with us, and we really thank. So I think we've had a fruitful discussion, and we look forward to the next one. I think it's definitely captured a lot of essence. Of course, time has been an issue, but then we've tried to touch on most of the things. I think the audience has also been very attentive. We've had more than 850 logins. Last I knew, about half an hour back. I'm not sure how much now, but 850 plus audience watching us, and thank you so much. This will be on YouTube as a resource, and that will be archived there. So we've got some kind of appreciation. Dr. Murli Mohan is appreciative that, excellent discussion, excellently moderated. So thank you so much, sir, for your encouragement. With that, we will like to close now, and we would like to again appreciate on behalf of CCI this opportunity that we've had, and thanks to all the office bearers and definitely the elite panelists. Thank you so much for sparing your valuable time. Until we meet on 2nd, this time it's on 2nd November, Tuesday. Because of the festival, we are definitely moving ahead from our scheduled Thursday. So please do join us, and we will take it forward from this, how to convert into publication, how to actually display your results. Thank you so much. Take care.
Thank you.
Thanks, everyone.
Thank you.